And welcome. You are tuned in to the Robert Wood Johnson Foundation Systems for Action Research Program and our Research in Progress webinar series. We come to you about twice a month with this series to feature one of our research teams who are studying innovative ways of helping to connect medical, social, and public health delivery systems in ways that can advance health and improve health equity across American communities. My name is Glenn Mays. I'm a professor here at the University of Colorado School of Public Health, and I have the honor of directing the National Program Office for the Systems for Action Research Program. If you're new to Systems for Action, we encourage you to learn more about us and engage with us. You can find out more about the research that we support on our website at systemsforaction.org. We study a whole variety of ways of helping to connect medical, social, and public health systems, helping these systems work together to advance the cause of health equity. And we come to you in this webinar series about twice a month, feature one of our research teams, a chance for that team to share with you what they're studying, what they're learning, and also to get feedback from our larger audience of people working to connect these types of systems in their own communities. A few logistical notes. We do have a pretty large audience today with us on the webinar. And so for that reason, everyone except for our panelists will be muted throughout the webinar. But we are going to invite questions and comments from our larger audience today as well. So when we get to that portion of the webinar, we would ask that you type your questions or comments into the Q&A box, which you should see a button for that down at the lower center of your screen. And in fact, you can type those questions in at any time during the webinar. And then when we get to the Q&A portion, I will get to as many of those questions as we can. Also of note that we do record all of our Research in Progress webinar sessions and post the recordings on our website. And so if you've got colleagues who can't be with us live today, you can direct them to the Systems for Action website and they can find a recording of today's session as well. Lastly, just a quick advertisement. Every year, we put out a call for new proposals, new ideas for research, for testing ways of helping to connect medical, social, and public health systems. So if you've got an idea for an innovative study, testing a way to help connect those systems, we invite you to keep an eye out for our next call for proposals. We anticipate releasing that toward the end of this calendar year in mid-December, and applications will be due later in the spring. And so again, invite you to keep an eye out for that and to potentially join our growing collection of research teams who are studying these ways of achieving systems alignment and achieving health equity. So without further ado, I want to turn it over to our research team that will be leading today's webinar. I'm really excited. The topic of today's webinar is looking at ways of connecting systems to advance early childhood development through partnerships addressing health and social service needs. We have, as all of our studies do, this is an interdisciplinary and collaborative research team led by colleagues from Mayo Clinic and from New York University. And so I'm going to turn it over to Dr. Maggie Paul to kick it off and to introduce other colleagues from her team.
Great. Thank you, Dr. Mays. Can everybody hear me? Thumbs up. Okay, great. Great. Thank you. So I'm so honored to be here today. And I just have to say thank you to the whole team at Systems for Action. We were sort of blown away by the amount of connection that this grant has offered us to other colleagues doing similar work throughout the country. And there were always opportunities to present and to learn about the work of other grantees, and that's so unique for a grant program, and we really have appreciated the journey. So we're here today to present our our final set of findings from this grant. I'm joined today by my colleague Rachel Masser, who's joining from NYU School of Medicine. I was with her as well as my colleague Dr. Carolyn Berry at NYU School of Medicine when all of this work was done. I've since transitioned to Mayo, and I'm doing similar work here, which I'll talk about later. So let's get started. Okay. So the Partnerships for Early Childhood Development, or as we call it, PECD program, was started by the United Hospital Fund in the spring of 2017 and chaired by Dr. Bernard Dreyer at NYU Grossman School of Medicine. Initially, there were 11 clinic community partnerships. Well, I'll say more about that in a moment, involved. And at the final stage, at the point where we got to outcome evaluation several years later, there were 7 of those teams remaining. Which is, not so bad. There was some attrition due to very understandable real world circumstances. So we ended up with 7 of the 11 participating all the way through. The goal of PECD was really to support multi-sector partnerships that were focused on improving early childhood development through social needs screening and referral programs. The program, the PECD Collaborative, was really focused on the group of children age 5 and younger, but I will say that most of the teams had a broader age range than that. And support for the intervention and evaluation was distributed among several organizations based in New York City. And then, of course, our work that we did understanding the implementation and outcomes of this program after the pandemic occurred were fully supported by RWJF. So this slide is helpful because it sort of gives you a sense of the extent to which community partnerships varied across sites. This list changed a lot during the course of the several years that we were involved in the evaluation of the program. Just because of issues going on with the CBOs, for example, so one of the community-based organizations that St. John's in Rockaway was partnered with closed, and so they had to find new partnerships. And so I think that for very understandable reasons, the clinic community partnership was somewhat dynamic. I would say probably the exception to that is Gouverneur in Lower Manhattan, which had really long established community partnerships with the organizations listed here at the bottom. Another thing that was unique about this collaborative is that the history of partnership and the resources available to do this work within their own system really varied to a high degree. And so that was helpful from our perspective when we look to evaluate the program. So as you can imagine, the programs themselves varied in terms of the workflows and the staff involved, but at its core, these were all programs in which families were screened at well child visits in pediatric clinics and then referred by clinic staff to one of their community partners. A lot of other things varied, but that core program held across sites. So we set out to really just establish a plan to measure implementation and outcome. Then in our second phase, we conducted a formative evaluation during what I would consider to be the early stage implementation of the program. We did what we called a deep dive process evaluation in 4 sites that included site visits and interviews, clinic observations, that sort of thing. And then finally, we assessed outcomes via pre-post caregiver survey. 4 and 5 sort of go together because the survey was ready to launch in mid-March of 2020. And so we obviously didn't go through with our original plan and were really held up because of COVID for quite some time. So we ended up revising the survey to include some COVID specific questions, which I'll talk about in a bit. The goal of our S4A grant in particular was really targeted at understanding the impact of the pandemic on the collaborative as a whole, as well as understanding changes in implementation at each site. So to do this, we really relied on the implementation data that we had sort of planned pre-pandemic, but sites continued to collect during the pandemic. We also looked at caregiver survey data, and then we conducted caregiver interviews, just regular qualitative interviews, as well as photo elicitation interviews with caregivers to understand just the context of their lives to a greater depth. And then we conducted key informant interviews with a broad network of stakeholders, everyone from, clinicians and staff working in the clinics, in the participating clinics, to people involved at more of a policy level in the city and state of New York. So why intervene in childhood? Rachel and I and our colleagues have done a lot of work in social needs screening and referral in adult and pediatric care settings. But I just wanted to include this slide because I think it's important to recognize how those settings differ. So we know that even though children of low-income families are more likely to miss well child visits, most still attend. And we, of course, know that early childhood is a critical time for intervening on upstream risk factors. And paired with this, the last point I'll jump ahead to a little bit, pediatric clinics are especially well positioned therefore to engage in this work. They're used to screening for multiple things at these well child visits. And so in some ways it integrates the social needs screening and referral process is sort of more readily adaptable to a pediatric clinic versus an adult clinic, just because the structures are already in place to do a lot of screening and community referral. And last but not least, many social needs are recurring, and we collected data on this in our own work, which we'll get to eventually. And so it's helpful to have repeated touch points that are sort of planned, baked into a care plan for families to return and report back on potentially new needs. So as I mentioned, the specifics of each program varied, but in general, the staff, and again, even the staff members who were conducting the screening varied across sites, but some staff at the pediatric primary care clinic conducted social needs screening and referred families with needs to community resources, sort of acting as resource navigators. And then community-based organizations then took over and engaged with families and hopefully address their social needs. Ideally, then the community-based organization would have some mechanism by which they could report back to the primary care clinic on the outcome of the referral. And so, hey, you sent this family to us, here's what ended up happening. Not surprisingly, for those who are familiar with this work, that is a very challenging loop to close, so to speak. And so we've spent a lot of time working with sites, figuring out ways to overcome challenges with that closing the loop. So I just bring this slide up to focus on, I just wanted to point you to the left hand of this figure. Our study was really focused on understanding the implementation of the screening and referral process itself. So were people being screened? Of those screened, were those with positive needs given a referral, that sort of thing. And so we really focused on the left side of this diagram, and we weren't as focused on measuring longer term outcomes, although we get to some of these things like stress reduction in our survey, in our patient reported or caregiver reported survey. But I really want to emphasize that I think there's a lot of work still to be done in understanding the implementation of these programs and how to do it well so that you're reaching the appropriate families and connecting them to appropriate resources. So the timeline of our project ran from April 2017 through the fall of 2022. So we ended just about a year ago with data collection, and most of our analyses, some of the analyses, especially around the photo elicitation interviews, occurred later. And then our involvement with our Robert Johnson Foundation began in phase 3 when we really were halted because of the pandemic and regrouping around our study design. During the first phase, so this set of measures, I should say, was constructed to align with, let me see if I can actually use this, constructed to align with this left portion. So we really wanted to make sure we were coming up with measures to ensure that we understood what was happening with respect to implementation. So we of course wanted to know, who was being screened out of the target population, of those who identified at least one social need. We heard early on from staff that they were identifying, whether you want to call it false negatives or missed positives, but people who would report no needs, but then use the screening tool as a facilitator to bring up a topic related to social needs with their clinician or with another staff person, and then ultimately reveal a need. And so there was this was consistent. People never figured it, across all sites, this sort of remained a constant, that there was some subset of individuals who, for whatever reason, didn't think to or didn't feel comfortable disclosing a need on a paper screener, so to speak, or an electronic screener, but in conversation revealed a need. Then we wanted to look at, okay, of those who identified a need, who were referred to services. We also wanted to understand the refusal rate. So of those who had a need, who didn't want to be connected to a community partner, and also who refused services once contacted by community-based organizations if they agreed to a referral. Then we wanted to understand who was actually receiving services and whether the feedback was recurring and how frequently. So the secondary data are just that, they're secondary data. So we constructed with very strong input from the clinical and CBO partners that they didn't want to have like a parallel data system to track all this. Understandably, you can see the numbers here are pretty high in general. It would have been a lot of data entry, really just not feasible to have a parallel tracking system that's built just to measure implementation of social needs screening and referrals. So we developed our measures to rely on existing data available in the EHR. However, this is the best it got. So this is the best the data got. And I'm not saying that to be pejorative. I'm just saying it is really hard to wrangle data needed to measure implementation effectively from EHR data. So even something as simple as looking at the first column here, how do you identify, given fields in Epic or whatever platform you're using, who the target population is for a given day in the clinic? What's the denominator for this, for the number of individuals screened? And so this even though the measure seemed simple, and we felt, and the sites felt too, like it was important to try to track this in some way. I just wanted to highlight in yellow here that in some cases, like no data was available at all. And in some cases, it was only partially available. And so it's just to highlight, a reluctance on relying purely on secondary data systems to track these programs, because there are problems with them. And even when some sites, I'm thinking of the wanted help rate for site B here, they knew that so they got a number out of Epic, but they knew that this was wrong because it wasn't, they knew it wasn't 100% of patients, and we couldn't get to the bottom of what was going on with the data in that site. So it's important to kind of track to the extent possible, but and some sites were able to kind of get it together over the years that they were involved in the program, but it is really sort of a complicated thing, and it's helpful to have, of course, like a really close relationship with IT and flexibility with altering fields in whatever electronic health record system you're relying on for these data. But overall, we see that, to the best estimate, to the best that we could estimate, it seems like about half of those screens reported that they needed, those individuals screened reported that they needed help with at least one social need. So we also conducted caregiver surveys. These were phone-based surveys that were administered by our study team at NYU. Pre-post, but all during COVID. So I want to highlight that this is all in the context of a pandemic. Those who agreed to participate got a $10 gift card incentive. The first survey occurred sometime between the fall of 2020 and the spring of 21, with time to beginning sort of immediately there. So we wanted at least 6 months to have passed between baseline or pre and post. So 98% of our sample identified as the child's mother. So even though most of the households that participated in this study had more than one children, the survey questions were tied to the child who had a visit that day. And so 98% of respondents were a mother. I think all of our, when I get to it later, all of the caregivers who participated in interviews and photo elicitation interviews were identified as a mother. 40% felt comfortable speaking in Spanish only, strong preference for Spanish only, and 62% identified as Hispanic or Latino. So before we could ask people if they received, the help they needed from the program, we had to ask them if they remembered engaging with the program. And so 88% of program participants remembered being screened for non-medical needs. And those who remember being screened felt comfortable or very comfortable with being asked about non-medical needs. This is probably not as much of an issue now, but when social needs screening and referral programs were just becoming popular, there was this big concern that families wouldn't want to be asked about this sort of thing in a clinical setting. That is not true according to our sample. Of course, all populations are different, but we did not find that to be the case. And for those who did not remember being screened, over half, like 2/3, said that they would be comfortable or very comfortable being asked about non-medical needs. It was a little bit more vague for this group because they didn't remember the screener. So it sort of makes sense that they're not as comfortable, but those who remember being screened felt very comfortable overall. So most of the program participants who remembered being screened reported that someone from the clinic spoke with them. So they remembered that human connection as being central to the program. And that's reflected later on in our interview data as well. So the light bars on the top of each category of social needs, and this is the first of two slides, were measured at baseline, and the dark blue lines that follow up. It's worth noting that these are this list is very long, as you see. I'll sort of give you a preview of the next slide. So there's a long list here, and we wanted it to be comprehensive. So every clinic screened for the same set of core needs like food insecurity, transportation needs, but then there were other things that varied by site. So not everybody screened for cash assistance or desire for cash assistance, for example. So we wanted on the survey to kind of recapture the data, even though we had data from individual sites about social needs, just to understand a more varied list of social needs. So we see notably on average, and again, this is during the pandemic, needs go down by about 1, so 0.8 from pre-test to post-test. We see that other indicators move in positive directions. So the number of people not paying their full rent or mortgage, or those reporting that they didn't pay utility bills, goes down from pre-test to post-test. And also those on food stamps or enrolled in WIC went down from pre-test to post-test, which on its own I wouldn't say is a good thing, but we do see later on that it may be reflective of a decrease in food insecurity. Again, many people reporting that at pre-test that they would need help with cash assistance or childcare, even baby supplies, and overall, as with the slide before, the overall trend is a decrease from pre-test to post-test in terms of need for these services. Our major finding from the survey is that we saw a decrease in depressive symptoms as measured by the PHQ-9. And so this was statistically significant. It's one of our very, very few statistically significant findings from the survey. Overall, our results were very flat, I would say. But this really popped out as being notable. Also, a pretty dramatic reduction in the number who reported a recent increase in mental health issues among household members. And so these samples are different. This is the full sample at pre-test and the full sample at post-test. So these are not matched. We're not doing statistical tests here, but you just see that, it's moving sort of in a direction that suggests a decreased burden of mental health at the household level. Overall, I would just point out these are fairly flat, with a slight, increase in optimism. But overall, it was the participants were very distressed, like at least pretty much at both time points. We see that over 60% are reporting some or extreme distress in their daily lives. And so just, this is all just leading to our survey results, reinforcing our interview results, reinforcing our photo elicitation interview findings, which is just that this is a very overall sort of distressed population. Okay, so I'm going to just sort of see, you can see that there aren't major changes to talk about on these slides, but just really pay attention to the proportion who are somewhat or very concerned is just over half for all of these at baseline and at the follow-up period. We see there's a lot of concern around putting food on the table. This does not perfectly align with the need for food assistance. And so there's something going on there between being concerned and having it translate into something that they would actually like assistance with. But also a lot of concern about not being able to find employment or maintain employment, and a high degree of concern around getting sick. We interviewed 13 caregivers. So these were all mothers who had participated in the survey, 13 caregivers, which are spread across the 7 sites who were participating in this phase of the study. All of the interviewees identified as mothers, and most reported having multiple children, and just about half were employed. They were happy with the care provided by their clinic. There are a couple of things to note that sort of speak to implementation and future iterations of this work. So nearly all of the respondents felt strongly that a human interaction was really critical to their engagement in getting the resources they needed. And so they really liked being connected to a staff member or a clinician versus sort of just being given a handout and making the connection on their own. And another thing I'd like to highlight is that most caregivers who were connected to services, and this is true if you look at our pre-post survey results, most caregivers who were connected to services reported they still required assistance for new or recurring needs after that initial screening. And so just in thinking about the design of these programs, it's important to think about not only how can a clinic and CBO sort of initially partner and screen a big population, but like those partnerships need to be lasting because people go between the two very often. And so just highlighted the need for longevity and sustained multi-sector partnerships in the community. We also then conducted photo elicitation interviews. This is a qualitative method that allows participants to guide a discussion using photographs that they've taken themselves. And so our prompt to individuals participating in this part of the study was to take photographs of things that represent things in your community that help you achieve the best possible health and well-being for your family, and things that stand in your way of this goal. And so it's a pretty general prompt, like what are things that in your community that facilitate or hinder health? And it's intentionally broad because we didn't want to say, hey, show us all the ways, you appreciated this clinic community partnership that you're attached to. That's not what you want to do. We wanted to really understand the context of participants' lives. And so giving a broad prompt like this really helped facilitate that perspective. So individuals took photographs and then they met with our team. I've done PEI across different studies in person But this was during the pandemic, and everybody was so used to being on Zoom or video conferences all the time. So we had caregivers share their photos with us in advance of the interview, and then we brought up the screen so that they could direct us, towards which photos they wanted to discuss. But other than that, they really led the discussion. And so the caregiver responses allowed us to really, just like I said, see their everyday experiences, and it wasn't guided by any preconceived notions that we had, that we would have prompted them to discuss, any specific topic. It was really an organic conversation that they led. So I'd like to share I'm just going to share 3 of the photographs. Today, Rachel and I are actually writing a paper on photo elicitation interviews across several studies, and PECD is one of the studies that we're including, and the 3 photographs that I'll discuss today are the 3 photographs that we're including in that paper. So this photograph taken on the left was a mother who had, interestingly enough, not reported having any housing quality issues on her repeated screenings at well childhood visits. And then sure enough, we have this photo elicitation interview with her, and the first thing she starts talking about is how this little space heater is her savior because it always works, and she has a young baby, and so she puts it in the baby's room at night to make sure that the baby's warm enough, and this is all because the landlord isn't providing sufficient heat in her building during the winter. And so there's something to say here about like the resiliency of the families being screened for needs at clinics. And sometimes I think, these interviews made us just realize that sometimes when people don't report housing issues, it's like, in my mind, yeah, the landlord isn't providing heat, but I've solved that issue on my own because look, I have a space heater. And that's really not the intention of the screener. And so I think there's, in some populations, it's just necessary to get at a deeper level somehow. And I think that that's probably relates back to some of the false negatives that we got, or mispositives, where people would not report an issue, but then they would bring it up with a clinician or a staff member later. So space heater, who knew? The next photo is of an intersection that a mother photographed because she has to cross through this dangerous, busy intersection every day, where she mentioned in a different part of an interview that people are running red lights, and it's really distressing because people are speeding. But she really, this was like a daily stressor and like top of mind for her when she thought about her family's health in her own community. And so this is obviously beyond the scope of a program such as the one we evaluated, but it's a daily stressor in her life. And so I think, I'll talk about this a little bit more when we get to more of the findings. But I think one of the reasons that we really value doing photo elicitation interviews during the context of COVID with these families is it made us really understand how varied and seemingly insurmountable some of the stressors are in their daily lives. And so I think, a program like PECD is never going to fix structural issues like this, but it could fix something with the heating. And so I think being more intentional about like how we link programs, screening and referral programs, to outcomes, and limiting it to outcomes that really should be impacted by a program such as this is important, so that you're not kind of setting yourself up for failure in evaluation phases. This is this was just a surprising photograph to us, because when we looked at this, we thought, oh, wow, I bet they're going to talk about something like kind of bleak, or there's no trees, or there's no park nearby. But this was actually a really positive photograph for the mother who shared it with us, because this was like the main intersection by her house. And she said, oh, the park's just over that way, and on that side, there's a drugstore and a healthcare center. And so this was sort of like her passport to her community. So it was really important that we heard her description of this photograph, because to us, it's, it doesn't have the obvious traffic volume that the photograph in this picture has, but just a very kind of similar large intersection, but she sees it as a very positive thing in her life. And so just wanted to share those two very different perspectives on a similar vantage point. So I'm going to walk through key findings from each phase of our study and try to summarize things in a neat way, but it was many years of research and it's not a neat, clean story to tell. But overall, I just want to highlight that we found that this work was possible. So screening and referral, maintaining clinic community partnerships is possible even during a pandemic, but really it does require resources. So the programs that were most successful had a program manager like person in charge of maintaining the relationships with CBO, maintaining capacity, troubleshooting when there was an issue, connecting families to resources, really making sure all the kinks in the program were worked out, and being a resource not just for patients and families, but also for clinic staff and CBO staff to go to when there was like an issue that needed to be ironed out. And so I would say ideally having a dedicated program manager, and to go along with it, semi-regular program meetings that include leadership from the CBO side and the clinic side are really ideal. It's really tough to integrate more work into like primary care, because primary care clinics, adult and pediatric, are so busy and asked to do so many things. But I really do feel, like I mentioned earlier, that the social needs screening and referral program is so well aligned with the goals of what the pediatric primary care clinics are trying to accomplish. And so we did find that just being really thoughtful about how to integrate the program itself into existing workflows was important. So spending a lot of time up front planning, talking with people who at every step along the workflow to understand what can we do to make this seamless for you. Some of the clinic CBO partnerships in the collaborative were new. And so that was an interesting thing to watch over time, just those partnerships strengthen. We did see that investment by the health system into the local CBOs was really a huge facilitator. So CBOs are obviously the lesser of the two types of organizations in general in terms of the resources available to them. Their CBOs tend to be much more resource strapped than healthcare systems, to put it mildly. And so, and I'm not talking about small, solo primary care practices here. I'm talking about larger healthcare systems. The clinics who participated in this were attached to larger systems for the most part. So they did have the financial bandwidth to support some of the work that the CBOs were doing. And in those instances, the relationships were really strong. The structures were in place. They had dedicated staff, and the whole thing just became a permanent fixture of the institution. We were kind of skeptical that these programs were going to remain functional during the pandemic because of just the level of chaos going on in the world in general. But we did see that that the clinics were really able, and CBOs were able to establish trust with caregivers, and caregivers really look to clinics in general in our group as a resource for them in a time of need. And so that was interesting to see. And I'll talk a little bit more about that when I talk about the survey findings. As I mentioned early on, tracking implementation for these types of programs is very challenging, especially when you're trying to track information from one agency to another. I know that there are platforms available like NowPow and so forth that are trying to make that easier, but it's a double-edged sword. So in New York, even during the time that we were engaged with this group of clinic community partnerships, we heard a lot from CBO partners about, oh boy, yeah, I'd really, I'm partnered with two health systems and they use two different platforms, and I'm so happy we're getting referrals, but boy, it's a lot of work to train an entire staff to operate on two different platforms that don't speak to each other. And so I think there could be some better alignment among healthcare organizations in a given geographic area. I think they've done this in North Carolina where they sort of all use the same platform, and that's very helpful on the CBO side of things. So I think there's a lot of room for improvement, and that tracking implementation will be easier to the extent that these systems can be aligned to a higher degree. And then the contextual factors really were highlighted across every part of our study during COVID. So every one of the 7 sites, site being the clinic and their CBO partners, was very different, and they had different programs, they had different levels of resources, they had different populations, and the populations they served had different needs before the pandemic and during the pandemic. And so even within the same relatively small geographic area of New York City, it was like 7 sites, 7 different programs. And so the contextual factors and the importance of those multi-sector relationships at the local level became really, really important. Again, I'm not going to belabor this anymore, but it really did come through during every part of our study. As I mentioned, we were sort of surprised that families participated, but because they did, we saw that there was a substantial increase in needs among families from prior to the pandemic to after the pandemic. But clinics were largely able to adjust to these increase in demand, that is, by securing new resources from the community. So one of the sites that I'm thinking of in particular got a big grant from a local organization to provide cash assistance to the families that they were serving, which was just made a huge difference in the daily lives of their patient and family populations. Telehealth was perceived as a positive addition overall to clinic operations. And so that seems like perhaps not so surprising now, but when COVID first started, we weren't sure how this was going to work, especially in a pediatric setting where these screenings have been conducted at in-person well-child exams for the most part. So each site sort of did it differently. Some adaptations were more successful than others. There were some sites who really increased their screening rates dramatically during the pandemic period, because they started like just going down their roster of families and screening everybody on the list, and just being extra aggressive about outreach because they knew families were struggling and they wanted to help. And so a lot of surprising I would say the level of engagement between the clinic in particular and families was surprisingly high, even just within the first month of the pandemic coming to New York. And so that was encouraging to see. Okay, so we, as I mentioned, with respect to the space heater picture, we really uncovered new needs in some of these photo elicitation settings. And so I think, really paying attention in future research on how to, especially among families who are really resilient and finding ways to cope on their own, how do you get through to them and say, no, really, there are resources available to you for this, for X, Y, and Z resources. And so we saw it with housing quality, and also we see it in our data among food insecurity, even just within the same survey, people reporting that they're somewhat are very concerned about putting food on the tables, like half the sample, but only, a half of that group reported that they struggled with food insecurity. And so I think there's some real work to be done around understanding the disconnects and sort of finding a way to move past resiliency into a real offer of help. So when it came to keeping families healthy, in our PEI results, we saw that a lot of it was structural and related to their geography in the community. So they really value being close to resources like grocery stores, transportation. And we saw a lot of pictures of bus stops, and medical care. Some people took photos of their clinic. And again, we didn't ask them, we weren't like, knocking them over the head. Hey, we're the evaluators of PECD. We really needed to know what you think of this program. It was a really broad prompt. And so we were surprised that they highlighted proximity to the clinic as a real help to their health. We heard a lot about neighborhood safety concerns, and a lot about housing quality. Some of the housing quality concerns did spike. So I think that's one of the things that moved in, like, quote unquote, the wrong direction from pre-test to post-test, was like the number of people worried about pests, for example, doubled from pre-test to post-test. So housing quality seems here to stay in New York. And so finding a way to address issues, forget about getting people into new housing units, but getting landlords to engage in appropriate maintenance and provision of heat, especially during the winter, is there's room for improvement there for sure. The sample, again, all of whom were mothers, also expressed that they really valued opportunities for social connections. We heard this through one site in particular, that they had started like a breastfeeding group for mothers, and that was like a real hit, not so much because they needed help with the like technical aspects of breastfeeding, but they really valued having that social connection, and it was in the clinic and it was in a really safe space. Others mentioned that they really value their church community, especially during the pandemic. And so finding ways to strengthen, to offer families safe spaces for new social connections could be one direction to take this work. And then they also valued, as a mom of two myself, I sympathize with this, or I agree that you need time for relaxation. So, and we were doing interviews with these mothers in their homes for the most part, and you can just see like the chaos around them. And so, and they're also on top of this. This is the same people who are reporting that they're worried about food or worried about, employment. And so there's just these issues just sort of compound over time. And so finding time for relaxation, we got a picture. Rachel and I laughed about this with the mom during the interview, but she included a picture of like a remote control, and it was like, it was like for the TV or something, or for the stereo, and it was like a way to distract her son. And she viewed that as a way to keep her family healthy, because sometimes she was so stressed that she really just did need like 5 minutes to herself. And so these overall helped us really understand the extent of stressors in the lives of these families on a daily basis. And it, in that way, really helped us better interpret the relatively modest findings of our pre-post survey. And so I think that was, something that we were initially a little bit confused by, honestly, when we were interpreting the survey results, but really digging into our photo elicitation interview data made us think, oh, wow, it's actually just nice to see that things are moving in the right direction, even if they're not statistically significant, or that we do see an overall reduction that was statistically significant in average number of needs and PHQ-9 scores. And so you certainly can't attribute a change in PHQ-9 to this program in particular. But in general, it seemed that this was an important resource for families, even though it wasn't going to fix everything. And I think, honestly, that's good enough, given that it's based in a clinic that's doing a lot of other things at the same time. So I think in the context of, a supportive web of social resources available in a community, this kind of screening and referral program can be really effective to connect families to needed resources. I'm going to wrap up in just a minute, but I wanted to share just a few things that we're working on now. So, and Rachel, feel free to jump in if you want to mention anything more about this project, but Rachel and Carolyn are continuing to engage with New York City Health and Hospitals Corporation, which was a partner in the PECD collaborative on social needs screening and referral evaluations, or I should say evaluation of social needs screening and referral programs that H&H is implementing in both adult and pediatric primary care settings. And then at Mayo, I've started working with a team in the Mayo Clinic Health System on piloting a health equity coordinator role. So this is a one FTE dedicated program manager for their social needs screening and referral program, who works on not just connecting families to resources, but also on establishing and maintaining a really, healthy network between the clinic and the community-based organizations in the region that she works. And so in the pilot study, they've opened up this previously had been a person dedicated to one clinic in Mankato, Minnesota, and is now expanded to include a broader region of clinics. And so we're sort of testing the scalability of this kind of role, which is especially important in places like the Midwest, where you have like a lot of rural clinics and maybe not the capacity at any one given a clinic in particular to justify a dedicated FTE. This is in contrast to a place like New York, where most of the work that we did was in really busy primary care clinics that were based in hospitals. And so there was a high volume of patients, and one FTE would be, fully engaged with just that patient panel alone. So we continue to think about this work in different contexts. I also want to highlight a project that was sadly, I was put here lost to circumstance. So we had started working with the New York City Department of Health and Mental Hygiene years ago on a proposal. It was actually an R01 proposal that never took off, but just because of turnover at NYC, at the Department of Health in New York City, it never took off. But I think this is really interesting work, whether it's in New York or somewhere else. But we were going to try to create a more formal connection to the public health system in New York, and really engage them in helping small, solo, independent, not necessarily solo, but small. So like, let's say fewer than 5 FTE providers who were interested in doing social needs screening referral, but didn't have the resources to do it. And so we developed this model where there was going to be sort of a remote team based at the Department of Health who would just get call lists from the clinic and screen patients prior to calls, and then generate referral sheets that they would then send back to the clinic for delivery during the visit. We were still honestly working on the delivery model, and it was already going to clearly vary to some degree across clinic sites. But I think there's a lot of work to be done around figuring out how to engage really low resource primary care clinics in this work. So people who are interested in helping their patients in this way, but don't have the capacity to, I think it's a perfect opportunity for local health departments to step in. That said, local health departments are also often very strapped for resources, which is why we were applying for an R01. But if anyone's interested in talking about this or anything else that we talked about today, please reach out to me. I put Carolyn's email here as well. And I also just wanted to highlight that we'll be at conferences. These are just conferences that we both have coming up in the next year. We're presenting on other studies, but we would be happy to connect in person about this work at any point, or via FaceTime if we don't catch you at one of these venues. So I will stop there. Thank you.
Fantastic. Thank you so much, Maggie. Wonderful, really important research. We do have a few minutes for some questions, and I know that we have some questions that have come into the Q&A box. So let's see if we can get through a couple of these. First question had to do with electronic health records and the fact that many times EHR systems are not set up for tracking, screening, and referrals of the type that are implicated in this study. So question about whether this project provided financial support or other kinds of support to help clinics modify their EHR systems to better accommodate this model. Any thoughts there?
Yeah, that's a great question. So the sites participating in this got very, what I would say, modest grants. So, and it was really to support a staff person. So they would get, somewhere between someone around 50,000 a year. Don't hold me to that, but it was a pretty modest grant that was really intended to support a real live person in doing the work. So maybe some sites use a portion of that pot of money to pay. I don't, it changes how by agency how this works, but to engage with their IT departments. But no, there was not explicit funding for this. One of the sites that was really successful in tracking this did it through smart sheets. Like they had sort of a parallel tracking system. They were also like one of the smallest sites. So I want to mention that because that doesn't fly at like really high volume clinics, and just thinking about the analysis of that and the potential for data entry error, like it's really, the data piece is a sticky issue. But no, they did not receive explicit funding to participate in that. I should have probably also highlighted that people loved participating in this collaborative. They really loved, especially before the pandemic, we had face-to-face meetings where we would all like convene real life in person and share a day together. And it was a CBO team, clinic team, local foundations, evaluation team, stakeholders. So local health department was always present. There were several departments in the local health department in New York City that were engaged in this work in some way, shape, or form. And they were there. People from the state public health agency came. And so that provided a lot of incentive for participation, which is why I think it was so high, even though the grants were somewhat modest. But yeah, we had I should have mentioned that up front, that the fact that there was a collaborative, not totally dissimilar from why we really value the S4A program, that was really highly valued by people as well.
Wonderful. Very, very helpful. We've got a couple of other comments from attendees about both related to the issues of stressors or concerns that may not have been picked up in the screening tool, but came through your other mechanisms like the photo elicited interviews. And so one person indicates that those issues seem to be related to the phenomenon of weathering. It's been well documented among historically marginalized populations. Another person mentions the concept of daily ongoing traumatic stressors as being some of the kinds of things that you may be picking up. I wonder whether there's more that you want to say about how we can improve systems' ability to pick up on those kind of stressors that aren't necessarily picked up on these kind of more formalized screening tools that we're currently using now.
Yeah, I also think that there's just like a huge need for mental health resources among this population as well, and that was true over time. Not just for the screening in a pediatric setting really allows you to get at household level factors, and so we heard caregivers reporting on their own well-being, mental health well-being through PHQ-9, but they also reported half of them were deeply concerned about family members' mental health. And so I don't know the answer to that, but I think that two things are true. I think that we need to be really careful about what we promise with this sort of program, with a social needs screening and referral program. I think these can be successful programs if you limit what they're accountable for. And I think it's more like this. I really feel like our data provided an insight into a gap that's not addressed by this program, which is like, how do you begin to address the magnitude of stressors that are sort of structural in nature in a clinical setting? Like, how do you use, maybe it's not that they want to visit a food pantry, but maybe they need some other more intensive resource available to them on a daily basis. Or maybe if this was like a 5-year longitudinal study where they had regular touches with the CHW, we would see some of that unloading, and we would see that false negative rate decrease, because I do think that the human connection for a program like this, and really people feeling like they had a human supporting them, was really, really critical to engagement. So I think those are excellent questions, and please study it.
Fantastic. Well, we are at the bottom of the hour. So again, I want to thank you so much to Dr. Maggie Paul and all of your colleagues and collaborators in this great work. Thank you so much for sharing your work. I know that you're open to hearing from others who may have additional questions or want to be able to replicate some of the strategies you're using there. So people can feel free to reach out to Dr. Paul and her team, or reach out to us at the Systems for Action program, and we can help connect you to this wonderful group of researchers and this body of work. Thank you so much. Thanks for joining us today, and hope to see you at future editions of the webinar. So long, everybody.